Hello, everyone. So, welcome to another interview of a very, very special guest, someone who's very close to me, my mentor, my teacher from my ILBS days. I'm very pleased to welcome Dr. Amar Mukund, sir, on my YouTube channel. Dr. Amar Mukund is my teacher, my mentor from ILBS Hospital, New Delhi. He's the current HOD, the Dean exam sections of ILBS. He's the HOD of Interventional Radiology there and the program director. And so it gives me immense pleasure to welcome Amar sir. Welcome, sir. Welcome to the show.
Thank you, Dr. Rishabh. Indeed, it's a pleasure and it's an honor. I know you have a huge fan following, and when you said that you would like to interview me and give a message to all the aspiring medicos, especially the radiologists, so that really echoes with my concept of spreading the knowledge and similarly making people aware of what is happening in and around radiology, interventional radiology, how things are moving. And I loved your efforts. These are really appreciable. And thank you so much. I really, take it as a very kind gesture from your side for taking out time and calling me for the interview. Thank you.
My pleasure, sir. It's always an honor to talk to you as a teacher and as a human being as well. Sir, first questions first. Since this video will mostly be watched by radiology residents and those who are aspiring IR, so let me first introduce intervention radiology as a specialty because even within medicos, I think a lot of students, MBBS students, interns, postgraduates, radiologists even don't understand the whole scope of intervention radiology, right? So let me first take this opportunity and ask you, how is it different from diagnostic radiology?
So interventional radiology is most like a surgical field. So why I say a surgical field? Because these are procedures which were at the time were being performed by surgeons by open laparotomy or maybe any kind of open surgical procedure, which has been reduced to very small procedures, which now includes few armamentarium, like we use needles, guide wires, catheters, and through these catheters only we may deploy many things, maybe stent, maybe coils, maybe any kind of device like plugs. So embolic material. So or you can even do atherectomies and other things. So definitely it's a totally new division, but the work what we are doing is a kind of thing which a surgeon was supposed to do. And how it differentiates from diagnostic radiology, that's a very, very important and pertinent question. So, diagnostic radiology is like, you are giving insights to a physician by virtue of your knowledge in anatomy and then looking into an image. So it started with X-rays and then further into bariums, and then radiology took a great leap by introducing ultrasound, and then there was no turning back, like CT scan, MRI, and then volume CT and everything. And today we know. And similarly, DSA. So this is how radiology evolved. But then, if we see from where intervention came, so intervention, so Charles' daughter started it way back, but that was taken up by cardiologists more eagerly than our fellow radiologists at that point of time. Maybe because we were very happy doing the work of imaging, and that was a simple work. And naturally, as a human, we tend to try to do slightly, easier works. Whoever, so smart people actually like to do easier work. But having said that, clinics are clinics where you are actually treating a patient and trying to, interact with the patient and trying to get a feedback. And you like patient appreciating your work and actually telling you, "Ki, Doc Sahab, you treated me, and now I'm absolutely fine. And thank you so much for whatever you did." But once you are deep into radiology, then you realize at some point of time, ki actually what you are doing, you are in a closed room, reading images, giving a lot of insights. In fact, everybody is on dependent on you, but the patient never realizes the kind of efforts you put to make a diagnosis.
Yeah,
And then it pinches, ki, look, majority of the work, they are in trouble. I'm doing, but the recognition, what I should get, I'm not getting. So here it bridges that gap,
yeah.
and you are able to actually, do some good work. So here, diagnostic work is definitely done, but simultaneously you do interventions where you treat a patient and you get all kind of patients. They tell you, they come to you, they tell you that they have been treated and they feel very happy about it. So it's a very enthusiastic field, but yeah, more like a surgery. So this is what I'll tell you. And we can elaborate it further. I think you will have more questions to answer. I think
Yes,
no,
sir.
not to further,
Right, sir. Like
stretch it.
when I started my IR journey, a very senior professor told me that IRs are essentially, plumbers of the human body. So every vessel we can access through one tiny incision in the groin or the wrist and access any vessel in the body. And that is the beauty of IR, with very small incision, 1, 2 mm incisions, with the help of long catheters, guide wires, balloons, we can reach any vessel and, treat it. So that's the beauty of IR. And as Sir rightly mentioned, it bridges the gap between diagnostic radiology and clinical medicine. So you are into clinics, you get that feedback. It is, in fact, a very gratifying branch, subspecialty, rightly said, sir. Now, sir, let's come to the current scope and importance of IR. Over the years, as you have seen, since you are a very experienced interventional radiologist, how has the practice of IR progressed over time?
So a very important, a very pertinent question. So look, I'll tell you my story. I did my MD in Gwalior, and that was a very good department, but there was no interventions at that point of time. And my first department where I actually saw interventions being done, because in Gwalior I used to just read books and then understand, and we used to just read it for a passing examination because if it comes in examination, you need to know, but there was no first-hand experience except for fine needle aspiration. So only fine needle aspiration was a procedure which we ever did. Then the first thing when we came to SGPGI, I was in SGPGI, and my first posting was DSA. So there I learned what intervention actually means, and the first femoral puncture. In fact, that was also a bit scary thing. You puncture a femoral artery, and suddenly you see a spurt of blood coming out, and sometimes the blood pressure is high. It even reaches up to your face, and you are taken aback. So first thing, but still, that's easy because as soon as you put a guide wire into it, it stops. And then second problem is as soon as you compress. So this is so this is how it started. But yes, you as rightly said, you said that it is a plumbing job. Yeah. So I agree. So those are the two important vascular things which we do in interventions. One, wherever a vessel which has to remain patent is closed, you open it, and similarly, if there is any bleeding point where a vessel needs to be closed, so we do plug it, we close it, we coil it, we embolize it. So these are the two most important things what we do in interventional radiology as a vascular procedure. But the scope is not limited to vascular radiology. It is even other things. So at that point of time, vascular interventions were less. There were only few institutes, maybe SGPGI, maybe Sri Chitra Institute, and AIMS and PGI were also doing. Neuro work was the predominant work at that point of time. Body interventions were slightly on a lesser side, and FNACs, biopsies were taking up. Biliary drainage was considered a major procedure. Pancreatitis drainage was a major procedure. So these were the major procedures which we nowadays is considered the basic ones.
Right.
So this started. Even the stenting was not done so frequently. Biliary stenting was a major procedure. We used to go to watch how biliary stent is placed,
Mm,
and affordability was also low because there were no hardwares available.
mm,
But gradually, I would have seen only two or three stenting in a year.
mm.
And people said, ki, wow, you are so lucky. You have seen three stenting being done because putting a stent, and even at that point of time, the stent used to cost 50,000, 60,000. And at that point of time, rupee
Right.
value of rupee was very, very high.
Right, sir.
That was the era, and then I moved to All India Institute, where again we started doing interventions. And at SGPGI, still I found that the patients were a bit paying, but at All India Institute we found that the patients were very very poor, and then we started how to do interventions in them. So we had some homemade things like for embolization. Sometimes guide wires were cut and placed, and the coils were used to made handmade coils. So those were initial days. Otherwise, we used to use gel foam in majority of the places where it has to be embolized. Though knowing PVA particle was better, still we use gel foam. So but again, 2010 crossed and gradually things improved and more people, and then training also increased. So
Right,
with training, industry came, industry, and gradually more and more consumption and the cost came down. So it is always, once the demand is much, import is much, or production is much, the production cost. So this is how, and more people became inclined into interventions. And now what we see is a mature phase of intervention and actually doing good. So it was a hard time in 2006, and maybe 2026, 20 years down the line. What I see is the golden era. So yes, it's a sea change, and it's a very gratifying branch. Whatever you do, you are a clinician to surgeons, you are clinician to medicine, and you are a bailout person for any hospital. If
right,
they are unable to do anything, they'll call you.
right,
तुम कुछ कर सकते हो क्या? So
right,
this will be the first question because they know. And if you remember, many people will call you as magician, me magician. So okay, okay, because sometimes you do such a work where they'll say, oh, it's like a magic. So yes, it is like a magic. So I urge everybody to actually take interventions and get that title from your hospital. Like most of you, the your teammates will call you. Look, this is the magician.
right. So I remember similar case. I had just joined the hospital. I'm sure you would know the story, and it was a case of post-transplant. Patient had undergone a liver transplant, and it's expensive procedure, 18-20 lakhs procedure, liver transplant in a private hospital. And on day five, the patient's hepatic vein just thrombosed, and patient is on heparin double as an antiplatelets. They can't open, they don't want to open, and so they are like, can you do something? And in that scenario, if you open through a catheter, you thrombolize the veins, put in a stent, the patient recovers, the enzymes recover, the team is happy, the patient is happy. So in that way, it is a very gratifying branch for sure, right, sir? Now, sir, a very, very important pathway, which a lot of students also DM me personally, that what is the pathway to enter into interventional radiology?
So right now, because the curriculum of MCI mandates the each and every department wherever a MD radiology or radio diagnosis is happening, that basic training for intervention also happens. So that is a basic requirement for MD radiology. Somewhere it is better, somewhere it is not as good, but yes, that's a basic requirement. So if you are lucky to be in a department where you learn some of the procedures and techniques, it's very well. But even if you are doing a MD and maybe there are not enough opportunities, I think they nowadays, somehow, because the demand for such a minimally invasive procedures, like we said, we do a plumbing job, and more so even like abscess drainage, ascites, pleural effusion, and there are so many things which we keep doing, which are small procedures but very, very important procedures. So the overall integral role of interventional radiologist in running any department in a tertiary care center has become very important. So there are more and more departments, and since there are more and more departments, there are requirement of more and more people, and hence there are more and more courses coming up. So there may be a 1 year course, there may be a 2 years course, there may be a 3 year course. So mostly 1 year course are PDCC or PDF, that is post doctoral fellowship or postdoctoral certificate course. Then there are again 2 years PDCC, and finally nowadays we are fortunate to have DM in interventional radiology, and there are many many institutes which have a DM interventional radiology courses. So depending on when you get interested, if you are interested, maybe immediately after MD, you can get into any of the DM course. There are specialized DM like neuro. If you want to get body interventions, then you have body. And similarly, you have smaller courses for 3 months, 6 months in peripheral arterial. So you'll have to choose what you want to do. But having said that, in today's era, at least a year course is a mandatory. And maybe if you can get a 2 years or 3 year course is definitely a preferable one, but at least a 1 year course. And then you can choose what you are interested in, body interventions, peripheral interventions, neuro interventions, and then you can keep specializing and refining your skills because it is just as I said initially, it's like a surgical branch. You learn the tricks initially, then you master the skills, and mastering the skills is like another couple of years, and gradually then you get to know what is not to be done. After maybe 2 to 3 years, I can do everything.
Mm.
But when this confidence comes, you should also know where to stop and what not to do because technically you can do it, but clinically it may not be fruitful. So those are the learning which you gradually learn. But till that time, I think the opportunities are immense. Things are opening up like anything. In India, there are enough opportunities, and simultaneously, there are opportunities. Outside India, you have various fellowship programs. You can get into other things. So things are very, very good. So wherever you are trained, maybe in a state medical college or in a premier institute, so the difference is not much. Yeah, definitely there is a difference, but not much. You can bridge it, but you have to have that kind of attitude, that kind of enthusiasm in yourself, and temperament to learn. And if you have a temperament to learn, you can do it. As I said, I was from a state medical college and went to SGPGI. First time I saw arterial puncture, but yeah, I wanted to learn it, and today I'm happy I'm able to do it, and so a bit of it, whatever best I could have done. But yes, yeah. So this is how it is as of today.
Sir, you are a big name in hepatobiliary intervention in India. In fact, the leader in hepatobiliary intervention in India. And so I think your journey is an inspiration for people like me as well, who also aspire to be someone like you and do well both clinically, both professionally in my career. And I'm sure a lot of young IRs who are watching this interview with you also want to do the same. Now, sir, a very important question that those who are interested in IR, and this is something that I tell a lot of students कि if you have a little inclination towards IR, एक कीड़ा होता है कि ना चलो डीआर में हम हैं, रेडियोलॉजी रेसिडेंसी में हैं, एक दो पोस्टिंग्स लगी हैं, मज़ा आने लगा है बट श्योर नहीं है. So to those students, I particularly say that at least if you're not sure, do a 1 year fellowship. There is no harm in that. What is your opinion, sir?
So yes, 1 year fellowship is very good, and but nowadays sudden trend has slightly changed because what I hear, although if I talk about my institute, so still there is a lot of application, and every year I feel ki, I wish I had more seats and I could take more and more eligible people because every year I find such a nice people trying to get into intervention, and I'm very disappointed. I can take only three at a time, maybe every 6 months, six a year. But I want to take more students. But definitely there is certain restrictions and certain things, certain number of seats what we have at our place. But what I have been told by many people in different institutes that number of application for 1 year fellowship has gone down. That may be probably because of the kind of work what we get in 1 year. Maybe people are not happy with the overall experience you gain in 1 year. So if you want to do a basic intervention, then 1 year course is fine, but you'll have to see where interventions are being done. So due diligence is very important. And I think again, you can follow Dr. Rishabh, and he has a very good grasp in of what is happening in radiology and interventional radiology, and he keeps following things, and he's very updated. So you can keep following his channel, and he'll let you know what are the best places to do interventions. So if whatever he recommends, you can choose those places. Maybe he can rank from 1 to 10 or something like that. But yes, 1 year course is definitely the best thing to do because it will give you liberty to have your diagnostic skills. Suppose you're not sure, so you can keep doing your diagnostic. And apart from it, like we discussed, what is the difference between diagnostic and interventional radiologist? So I'll give you an example. So diagnostic radiologist is a person who does diagnostic radiologist and does basic intervention. And what I mean by basic intervention is like basic FNACs, biopsies, drainages. So this also accounts to one of the very, very important work. So even if you don't want to get into the very difficult ones, you can get into the smaller intervention, and it really works. So 1 year is definitely mandatory, but you can go into the 3 year course. This is what people are trying nowadays.
Right, sir. Now, sir, a very important question for all the students, and this is something that they really want to know, that what are the challenges in this field? Because there is a word in the town that since we are into clinical medicine and we are dealing with patients, so there is always a turf erosion or a turf war because intervention is minimally invasive. It requires a lot of heavy hard work. It is requires a lot of skill, so it is high paying, right? And so the clinicians also don't want to let go of this subspecialty as well. So what are the real challenges as an interventional radiologist in practice, and how to deal with it?
Yeah, so very important and pertinent question, and thank you, Rishabh, for asking it. I'll tell you again my story, is how it started. So when I went to my institute, I joined. So I was given my post was diagnostic radiology and intervention. So I was supposed to do diagnostic. So but since it was an intervention post also, so I used to get some intervention. And if you imagine what intervention I was getting. I was getting one FNAC a week. So this is what I was doing, four FNACs a month. Apart from it, the other interventions, what were being done was chemoembolizations, maybe two chemoembolizations a month, and similarly two tips a month. So there were four big procedures and there were four FNACs. That's it. So how it starts. So, one evening, fine evening, maybe I would have joined a week, and suddenly at 7 o'clock, I was about to reach home, or I would have reached home. I got a call, ki, look, you have to come immediately for PTBD. And initially, as we have a training, I started asking what is the indication, what is the PT, what is the INR. So, but I was told, ki, no, no, the patient is in shock and you have to come. So fine. So I came down. It was a pain, but I came down. I did a PTBD, and next day things were fine. Then I realized that every day in the evening I'm going to get a call, because the clinicians will do their work whole day, and once they fail, they'll call you.
Mhm.
So I adjusted. But gradually, they had a lot of confidence in me. Then things started moving. In the morning, they used to discuss the case with me. And then accordingly, I started getting cases in the daytime as well. Evening was definitely there, but daytime as well.
Mhm.
And then again, more and more confidence, more and more friendly conversation, and things started rolling, and night calls decreased, and day interventions increased. So this was one thing. Now coming to another aspect, like turf erosion. If you are good at your procedures, you'll there won't be any turf erosion kind of a thing. And if anything is simple, why do you think only you can do it? Simple things can be done by anybody. Suppose I talk about line placement. So what do you think? Before IR, were there no people putting lines? All the lines were being placed blindly. So if somebody is now using ultrasound to put a line, if a anesthetist is doing it, so he was doing it without ultrasound. Now he learns with ultrasound. So you shouldn't be, telling he is snatching. Actually, all IR procedures are a snatched procedure only, because somebody, either surgeon was doing it, or clinician was doing it, or medicine person was doing it. So we have actually, gotten into their field, and now they are again trying to take it back. But having said that, if your skills are good, they can't do each and everything. There will be complex cases, they will make complications, they'll send it back to you. So, you should be ready to both kind of scenario, where you do some good cases, where you do some easy cases. But yes, your skills should be good enough for very difficult and the complex cases. Once you are ready to take complex cases, there won't be any challenge. I'm telling this, and I think Dr. Rishabh will agree with me. He has experienced. Look, you don't get easy cases as often. Like I always स्पाइलिंग से कि यार कभी सिंपल केस भी ले आया करो यार
Right, sir, I remember.
because what you get is the difficult ones. But it's a challenge. You have to accept the challenge and say, yes, I can do it. The world is like that. So you have to be good at your field. There won't be any turf erosion, nothing like that, because everybody likes to do easy thing, as I said initially. So similarly, even in interventions, easy things, anybody will pick easy things. Maybe nephrologist, he will become interventional nephrologist. Similarly, gastroenterologist will become interventional gastroenterologist. Everybody will do interventions, but it will be the easy part. Wherever they are stuck, they'll look up to you. So we have to make our skills at such a level, take it to such a level where you can handle any complex case and there won't be any dearth of cases.
Right. What I personally also feel is that कि जो सर बाकी सब specialties हैं, the other subspecialty, be it vascular surgery, be it gastroenterology, nephrology, oncology, there this endovascular procedures is considered super specialization. So there are very few people who are catering to these very high-end procedures. And again, as you rightly said, the basics of these high-end procedures. So there are a lot of other clinical colleagues as well who are not so subspecialized, and they're happy to refer such cases to you if you have a good rapport, your outcomes are good. Uh, and the tough cases, which even those subspecialist, interventional subspecialists are not able to do, they are also they'll also refer you these cases. And sir, what I have personally also seen is that the awareness per se of intervention procedures being done by IRs is also a little bit increasing day by day. So gradually the workload is also increasing. And that way, I think it's a very promising field right now. As you rightly said, this is the golden era of interventional radiology. Every hospital has an in-house IR now, as compared to I think 5-10 years back when one IR was there for 4-5 hospitals, and he used to do freelancing here and there.
No, so just interrupting you in between. If I talk about 2010, so there were only four hospitals. If I talk about New Delhi, there were only four hospitals which were counted on fingers where interventions were being done. So first was All India Institute. The second, at that point of time, Medanta had come up. Apollo was there. Gangaram was there. These were the even Max Hospital never had interventional radiology services. Very advanced interventional radiology services at that point of time. So, this is how it was. And today you name a hospital and there will be an interventional radiologist. So things have changed. So in Delhi, this has changed. Similarly, even in tier two cities, you will find so many interventional radiologists. So how are these many interventional radiologists actually getting job? Because, work has been created. So awareness is there. People know these can be done. And more so, this is a very promising branch where it is a minimally invasive procedures. The hospital stay is less. Overall, patient outcomes are very, very good. And definitely you help many surgeons and physicians in treating very complex cases, maybe pancreatitis. Previously, the overall outcome of pancreatitis was very bad, but just putting drain in some of the collections helps them so much. Triple surgery, there is blowouts and you just plug them. That's it. Patient is treated. So, so on and so forth. So, any bleeding complications, you can treat it. Hemopsis, you go do bronchial artery embolization. Patient is treated. So, that's actually a magic. The patient was about to die and you did something, and patient is finally back to ICU and next day in the ward.
Right, sir, definitely. Now, sir, just last question, and we'll wrap up this session. Very important is the work-life balance and reward. How would you describe the work-life balance in this specialty, which a lot of students, especially radiologists, young radiologists, have a doubt about? And what is the most rewarding aspect of an intervention radiologist? Two things, sir.
So yeah, this is again very nice. I must thank you for actually taking out such a nice questions, and I'm loving it. So work-life balance is a very pertinent question, and initially maybe till the time your physician who is referring the case to you, you may have some difficulty because it's kind of a surgery, and he will send a case only when he has a confidence. So first, it will be difficult to get case. Second, you will get cases at a difficult time, maybe in the evening, maybe at the night. So if you want to establish your practice, maybe initially you'll have to face some this kind of challenges. But it is a initial. Once you have a rapport, you treat only five patients. I'm telling you, you don't even need to do 50. five good cases in the evening and you just politely tell कि sir थोड़ा सा rounds जल्दी ले लेंगे sir मुझे जल्दी कर देंगे तो so the person will understand कि हाँ यार मतलब he is also coming midnight running and then going back. So everybody is a human being and you are helping him out. So yes, things improve. And about work-life balance, everyday emergencies don't come.
Right.
Emergencies will come sometimes. It is, sometimes that you get very frequently emergent calls. Otherwise, mostly it is like infrequent emergency calls. So mostly you can balance it unless until you have a very high workload and very less manpower. But this doesn't happen as soon as because it is a paying branch where hardwares are costly and overall investments are high. That's why revenue is also high. So even if you are in a government or a private setup, in government setup, manpower is not a problem. In a private setup, because revenue generation is more, as soon as number of patients increase, you can ask for manpower. So these things don't matter much unless until you have established. Till the time you have to establish, maybe for 6 months or a year, maybe you may have some tough time where your weekends may be ruined. Your some of the night duties may be ruined, but overall things are very rewarding once you make your consultants happy about your work. Probably everybody understands that everybody needs a quality life and they respect it. They respect your skills. It's not like that. They are more thankful than anybody else. Then even our own radiology and interventional radiology colleague, because you save their life, they have to face patients every day, their attendants every day. If you save them in when there is a complication, they are really happy and they look up to you and they try to help you out as much as possible. So that's absolutely not an issue. We feel initially, so yes, there is an incubation period. Like any surgical branch, there is an incubation period. You may require to invest maybe a year, something like that, but not more than that. So you can consider it as a extended training for a year, and that works. And you'll be more than happy. Very gratifying. Patient will come. They'll give you all kind of responses, and sometimes really it feels so happy. पेशेंट हो सकता है आपको उससे बहुत फाइनेंशियली बेनिफिट नहीं हो, लेकिन जब वो आके आपके सामने मतलब मुस्कुरा के बोलेगा सर मैं चल पा रहा हूँ, मेरा तो ये ठीक हो गया, या उसके बच्चे आके आपसे बोलेंगे मेरे पापा ठीक हो गए, इट्स लाइक मतलब समटाइम्स यू जस्ट फील लाइक अरे यार मतलब पैसा क्या चीज है, दिस वाज द
हाँ,
बेस्ट थिंग व्हाट आई गॉट इन माय लाइफ. छोटा बच्चा आपके लिए एक ग्रीटिंग कार्ड अच्छा से बना के ले आया. दे क्लिक फोटोग्राफ्स. आई हैव सीन इवन पेंटिंग्स बीइंग मेड जिसमें कि आपको पेंट करके वो ले आते हैं. सो दीज आर द थिंग्स व्हिच यू रियली चेरिश. दिस इज बेटर देन एनी अवार्ड अ पर्सन कैन गेट. सो वेरी ग्रेटिफाइंग.
right,
So
sir.
work life balance and other things can be managed and you'll be more than happy. So I'll definitely recommend interventional radiologist as one of the topmost subspecialty amongst various subspecialty in radiology. And I urge most of them who are happy to take up any surgical kind of a branch.
Mm.
So IR is the key where you have both kind of life where you remain to be diagnostic, you are in the helm of affairs of the hospital, and you are one of the most key person. You are the surgeon will be with you, the physician will be with you, the patient will be with you, the administration will be with you, and you will be dealing with the most costly hardwares and the machines of the hospital, and people will love to work with you. So nothing like that. So with this, I'll end because I know it's getting too long. So, but yeah, IR is the branch to go ahead for those who are really willing to go to any kind of basic surgical branches.
Rightly said, sir. And I think that's a very good summary of the whole IR as a subspecialty. We have covered what's the scope of IR, how to get into IR, what are the working hours, what job description does it demand, and is it gratifying or not. So thank you so much, sir, for your time. And it was lovely talking to you, as always. And last closing remarks from your end, sir.
No, it's a wonderful, Dr. Rishabh. I really loved the way you took it forward. And my message to all my radiology colleague is like, even if you don't want to get into the hardcore interventions, which may be the vascular, the most complex one, at least try to get into the basic ones because that is the need of the hour.
Mm.
And once you do that, more and more physicians will have more confidence, because I see a lot of conflicts many times between radiologists. Like they have a complaint that clinicians treat us just like give us the report, give us the films, give us this, and not giving adequate respect. As soon as you start even doing fine needle aspirations, biopsies, drainages, that's more than sufficient to actually, they just become friends, and they don't complain. Otherwise they'll keep complaining कि आपने ये lymph node मिस कर दिया, आपने ये नोड्यूल मिस कर दिया, आपने ये कर दिया। उसके बाद वो सारी चीजें खत्म हो जाती है। they'll come and say कि अरे यार हो जाता है, कोई बात नहीं। So they'll, rather than you say telling that, he'll only come and say. So because you are helping them out. So I think intervention is really rewarding, maybe small, maybe big. It depends upon different temperament, like what kind of person you are, whether you want to take a lot of that kind of efforts or not. Would you like to wake for during midnight or not? But for basic interventions like drainages, FNACs, biopsies, I think it can go hand by hand with diagnostic radiology, and every diagnostic radiologist should do some basic interventions. So that will be my closing remarks, because if I'm unable to make people interventional radiologists, at least I would like them to take up some interventions.
Right, sir. Right, sir. Right, rightfully said. Some sort of interventions we as radiologists should always and always do, both gratifying and both for our practice and clinicians' practice as well. So with that, I'll end today's session with you, sir. It was lovely talking to you. If you have any queries, you guys, if you have any queries, please mention them in the comment section. I'll be happy to answer them. I'll see you in the next interview. Bye bye.